Okay, thank you. All right. So good afternoon or good morning, everyone. I'm Peggy O'Brien from SAMHSA Center for Behavioral Health Statistics and Quality, or CBISC, in the Office of Evaluation. Thank you for your interest in our webinar series. Today, we'll be discussing the use of quality measurement as a tool for continuous quality improvement at CCBHCs. My colleague, Shweta Palakode, and I will be your hosts today. Over to you, Shweta.
Great. Thanks, Peggy. Welcome, everyone. Thanks for joining us. So I'll just start by addressing some logistics. We are recording this webinar, and you should be seeing you can see closed captioning throughout the webinar. The slides, transcript, and the recording will be available about a week after the presentation, and we'll post it on SAMHSA's CCBHC website. And I'll post a link to the CCBHC website in the chat in just a minute. We do have a large crowd today for our webinar, which we're very excited about, but we do ask that you mute your lines and also turn off your cameras just to conserve bandwidth. You can add your questions on the Q&A chat box, and we will be monitoring the chat, and we'll address those questions at the end, towards the end of the webinar. We also have another chat function where panelists will add links and attachments related to the webinar for participants. Next slide, please. Peggy and I would like to share some acknowledgements to those who had a role in making this webinar happen. First, we'd like to thank SAMHSA's CCBHC team within the Center for Mental Health Services, CMHS. Thanks also to the National Council for Mental Wellbeing for helping us with scheduling and gathering attendees. We appreciate the support of the CMHS logistics contractor, AG Associates, and we also thank our SAMHSA staff, Selby, who is on our call today, who will help us with any Zoom-related questions or concerns during our webinar. Next slide, please. All right, we really want to know who's in the audience today. So we ask that you take a minute to let us know which of the options presented best describe your role or roles. You can choose more than one response. So Selby, whenever you're ready, we can open up the poll. I'll give it maybe 30 more seconds. Great. Toby, how are we doing with the response?
80% so far.
Okay. Let's wait for 10 more seconds. Okay, here we go. So we have mostly CCBHC-PDI grantees and IA grantees, and basically pretty, the responses fall under different buckets. So that's really great. Are we able to share the screen for the audience to see the responses, but if not, that's okay. But we do have a pretty good distribution of those options listed. We can move. Sorry, Peggy?
No, I was just going to shut that off. I'm talking to myself.
Oh,
sorry.
All right. No, we have a pretty great distribution of attendees today. So the intended audience is basically folks from the previous slide, prospective and existing CCBHC demonstration state staff and clinics, independent state CCBHC staff, expansion grant clinics, and also SAMHSA government program officers, or also GPOs. We also hope that our audience include those who are responsible for overseeing quality improvement for CCBHC programs, because the focus of this webinar is going to be on quality improvement at CCBHCs. So before I kick it off to Peggy, I just want to give you a snippet of what to expect from today's webinar. Today's webinar is intended to help you get ready to meet the requirements in criteria 5 for continuous quality improvement in the updated CCBHC certification criteria. So now that we have discussed the logistics and also what to expect for the next hour or so, I will turn it over to Peggy, who will walk us through the main content for today's webinar. Over to you, Peggy.
Thank you, Shweta. So this is our agenda for today. We will start with a general introduction to continuous quality improvement, or CQI, which I'll refer to it as. Then we'll talk some about the value of using quality measurement as part of CQI. We'll wade into the meat of our discussion with thoughts on how you as clinics and states can prepare to use quality measurement for CQI. Included in this, we will have a panel composed of an experienced demonstration state and an experienced demonstration CCBHC to talk about their experience over the past few years regarding use of the measures for CQI. We also want to let you know a little bit about the future webinars and who should attend them. And then we'll have time for questions, which will have to be from the written Q&As, given how many people we have on the webinar today. I do also want to note that the slides, transcript, and recording of the last webinar will be posted shortly, I promise. I also am aiming to get this one on the website much faster than I did the first one. We also are assembling questions asked in all 3 of these initial webinars into FAQs to post. And I do have a few slides at the end addressing some of the questions from last time. So after we get through questions from today, I can turn to those if we still have time. So, okay. What is quality improvement? Quality improvement, according to the Centers for Medicare and Medicaid Services, or CMS, is a framework that is used to systematically improve care. And the state of Minnesota Department of Health has defined continuous quality improvement as the continuous and ongoing effort to achieve measurable improvements in efficiency, effectiveness, performance, accountability, outcomes, and other indicators of quality improvement. I'm sure that you have all seen the updated CCBHC certification criteria that are posted on the CCBHC website. If not, you should take a look. These were updated in March of this year. On the next 3 slides, you'll see shortened versions of the portion of Criterion 5 that pertain to CQI. I will touch only on the highlights today. The sections do include CQI requirements beyond the use of quality measure results, and I'll cover those broadly to ensure that everybody is familiar with them. The link to the updated criteria is at the bottom of the slide, so when you can access the slides, all you have to do is click on the link, and also it is on the SAMHSA CCBHC website. We also will put the link into the chat or Q&A feature, whichever one we're using for that. Okay, so Criterion 5B is the section of the criteria that's relevant to CQI. So CCBHCs are required to develop, implement, and maintain a CQI plan that includes a critical review process to review CQI outcomes and implement needed changes to improve the quality and timeliness of services. This harkens back to the CMS definition that I mentioned a minute ago that refers to a framework for systematic improvement. And I will also note that the CCBHC's medical director's involvement is important for aspects of the plan, particularly those that apply to the quality of medical aspects of care, including coordination with primary care. The CCBHC's CQI plan focuses on indicators to improve behavioral and physical health outcomes and to demonstrate improvement in performance, such as reductions in emergency department use, rehospitalization, and repeated crisis episodes. The CQI plan that is developed by the CCBHC must address how the CCBHC will review known significant events, including deaths by suicide or suicide attempts of people receiving services, fatal and non-fatal overdoses, all-cause mortality among people receiving CCBHC services, 30-day hospital readmissions for psychiatric or substance use reasons, and any other events that either the state or applicable accreditation bodies might require as appropriate for examination and remediation as part of a CQI plan. Now, I really want to emphasize that this is a plan for review of known events, not a requirement that you collect these particular data, although you certainly can if you wish and if it's possible. We do know, however, that it is not always possible to be aware of every suicide attempt, overdose, or death by a person receiving your services. The CQI plan, however, is required to be data-driven to the extent possible. Thus, at a minimum, it must address the data resulting from the required CCBHC collected and, as applicable for the demonstration, state-collected quality measures. The certification criteria also require the plan to have an explicit focus on populations that are experiencing health disparities. However, that may be identified in your service area. And to address how the CCBHC will disaggregate data from the quality measures and, as available, other data to track and improve outcomes for populations facing health disparities. I will add here that, and we'll get into this more in later webinars, that there will be different requirements for measure stratification this time, which do relate to this. We will still have modification, we will have modification to the payer stratification, which is retained from last time, but we will also have stratifications by race and ethnicity. Okay. Now I want to move on to providing you all with a little information on how I see the value and use of quality measures for CQI, largely based on the results to date from the national evaluation of the demonstration that's being done by ASPE, otherwise known as the Assistant Secretary for Policy and Evaluation. With regard to the quality measures that have been in place as part of the Section 223 CCBHC demonstration, the evaluation shows positive changes in care delivery associated with measures that were collected and reported by CCBHCs. These include more consistent or more common screening and assessments for problematic alcohol use, tobacco use, depression, and suicidality, the use of structured and standardized instruments for those screenings, conducting and documenting follow-up to those screenings, and conducting rapid or same-day client intakes. The evaluation, however, contains more limited evidence on changes in quality of care associated with the state-collected measures in the demonstration. That does not mean that the state-collected measures are not valuable. For one thing, the evaluation thus far covers only the first 2 years of the demonstration, and there is an unfortunate lag time in the use and reporting of measures relying on claims or encounter data. The lag in claims data makes it difficult for clinics to react quickly to those state-collected measure results. It does mean, however, that it is imperative for the demonstration that CCBHCs understand that the states are reporting these measures by clinic and that working to improve services associated with those state-collected measures is part of the CQI. It also means that states should work closely with their demonstration CCBHCs to get them feedback as soon as possible so that adjustments can be made. I'm hoping we'll be able to discuss this a little bit more shortly in our panel discussion. Before we turn to that, though, this slide is adapted from a chart in the 2021 report to Congress from the ASPE evaluation. These are the 9 measures that have been reported by the demonstration clinics to their states and then to us at SAMHSA since the inception of the program. The evaluator aggregated these at the state level. These results are from the first 2 years of the demonstration. The green arrows represent improved rates over those first 2 years. Red indicates a decline, and the gray stop sign represents stable rates during that period. These are very positive results, particularly given that most of the reporting clinics had never done anything like this before and were largely novices to reporting quality measures as well. For those who are interested, the link to the actual report to Congress is at the bottom of this slide, and we will be placing it in the chat or Q&A feature of the webinar. Now I want to dive into some actual experiences that our guest panelists can share to highlight what they've done, problems and challenges they've encountered, and solutions they have developed over the long haul between 2017 and now to make use of quality improvement in their quality improvement activities. Before we start, I want to express my sincere gratitude to our panel today. These individuals have been involved to a greater or lesser extent in the Section 223 CCBHC demonstration since its inception in 2017. We have with us from New Jersey, Dr. Robert Eilers, the medical director of the New Jersey Department of Human Services. Vicki Frizzalone, the manager of the integrated services for the New Jersey Department of Human Services. And Charlotte Sadadice, the primary researcher in that department for the state CCBHC demonstration, speaking from the perspective of a demonstration state. And I hope I didn't butcher anybody's name too badly. We also have Emma Kelly Robinson, who's the operations manager of Options for Southern Oregon, one of our longtime Oregon CCBHCs. I recognize that our panelists represent only one state and one clinic in a different state, and that other states and clinics have valuable experience as well. For that reason, I'm hoping that after we complete our panel discussion, if any others of the existing demonstration states or clinics who are in the audience have additional insights for new reporters on using quality measures for CQI, at that time, I will ask those individuals to raise their hands, and Selby can unmute you based on those raised hands, or you will be able to comment for the audience in the Q&A feature. So this is my first question, and it goes out to any of our panelists, state or CCBHCs. What are the greatest benefits that you have seen from using quality measures to improve the quality of services in the CCBHCs? And I cannot see any of you, so I'm going to have to rely on you to speak up.
This is Vicki from New Jersey. I think that the quality measures have been a real positive for the CCBHC overall. And there's a few areas. I think first of all, it gave us an objective way to assess provider performance, right? So we could take out some of the subjective feelings we may have had about a provider from previous experiences, or understanding, looking at just a few charts. We had the data, and it was really helpful for us then to make those assessments. It was really helpful also for ongoing provider improvement for CQI activities. One of the things that I think it allowed us to do is help providers target their CQI activities, right? So we had we required very specific CQI projects, and we gave providers a template. But one time we allowed the providers to pick any performance measure that they hadn't done too well on, or they wanted to improve. And another time we asked them to pick a specific metric that they hadn't improved on very well. And then we met with each of them individually to go over those plans and talk to them about this is a great plan. How will it affect your performance? How is that connected to the actual metrics? When will you expect to see this? And the providers were really pretty excited to be able to do something that targeted around a CQI activity. And we wouldn't have been able to do anything that targeted without having the performance, the quality measures. And then kind of related, but is that it gave us some data to share, right? So we could share that with other stakeholders around certain metrics. And that really provided a lot of enthusiasm around this among different systems for the CCBHC, which was great because it helped us, want people to expand it and grow it. So from New Jersey, and then I would obviously ask Charlotte or Dr. Iwas if they had anything that they wanted to share about that.
Thank you, Vicki. Charlotte or Dr. Eilers, do you have anything you want to add?
Sure. I'll just say also that I think the performance measures acted as a form, really as an incentive. And the fact that they were part of the quality bonus payments made that real. And, it's a form of really performance-based payment in a way. So I think that's another element of benefit. Thank you.
Thank you. Okay, I'm going to pose the same question to Emma. Do you have anything that you really wanted to highlight about benefits that you've seen from using quality measures to improve quality of services at your CCBHC?
Yes, thank you. And I think we at Options for Southern Oregon have seen very similar to what Vicki was speaking to around kind of staff development. One of the greatest benefits we saw from these quality measures were really for our clients as well. Our strongest quality measure still is our hospital follow-ups that we complete, being able to access the person while they're still at the emergency room for mental health reasons prior to discharge, helping ensure they get connected to those ongoing resources, whether it's an intake or next scheduled therapy appointment, and then following up with those people at 2 days, 7 days, 30 days, and ensuring that kind of coordination of care is continued after they leave the hospital or have access or have contact with our 24/7 crisis line. Another huge benefit for us not only is having the tools, but also using the tools, right? So a lot of the standardized tools that we use now that's kind of your next question, Margaret, sorry, I'm jumping ahead a little bit. But it was really allowed us to develop our staff skill set as well, because we did not use most of the standardized tools or evidence-based practices prior to CCBHC until 2017. Another area that we've really developed because of the quality measures is around that intake time from an eval. And we developed what we call our open access process. So just our intake, same day access for clients. Patients are seen the same day. They leave with a completed mental health assessment and treatment plan and their next scheduled appointment. 25% roughly of our intakes are screened out, so they complete the assessment and no further treatment is needed. So being able to have some of that data to share with our staff teams has been helpful, especially when we all are in our feelings a lot and experience really strong, sometimes subjective feelings about what's happening with clients in an organization. The quality measures and the data from those have been so helpful to share with our teams and be able to kind of address address issues that are coming up with the use of data. And sometimes they are supported, like our subjective experience is very similar to the data and what it's showing. So our regional open access, for example, we do cross county and across all locations. We have had remote workers from prior to COVID-19 happening. And so we really were able to establish that open access model for us. And so it really actually helped a lot during COVID because it was already kind of in place because of CCBHC. And then with our most recent CCBHC-IA grant that we received, we actually were able to expand our same-day access so that we now provide same-day access for mental health as well as substance use. And so we have same-day access intakes using a substance use assessment, getting a treatment plan, and a next scheduled appointment prior to that client leaving or ending their Zoom call.
That's wonderful. And because you got ahead here.
Yes, I can just keep on going.
Yeah, you can just keep going because this is a question that's aimed at you. What techniques did you use to provide feedback to your providers? Like, did you use dashboards or have regular meetings, or how did you communicate to them the results you were getting?
Any way possible. So a big piece, what you just mentioned, so going to our individual team meetings, larger supervisor meetings, management meetings, talking about CCBHCs, sending out emails. We had lots and lots of reporting that we use, reports and the metrics that we use internally. We have our quality assurance team that goes in and reviews those that data with specific staff or teams, providing feedback and direction, kind of how the measures are going, or if we're missing some, or just finding those patterns that start to develop over time, reviewing that data consistently to help identify those patterns and then address them as they come up. I think the hardest part that we experienced with providing feedback is really getting our providers to understand why the whole health of a person is so important. Their training doesn't necessarily support that. And so CCBHC really challenged our providers in that way. And so we had to develop specialized trainings about incorporating some of the whole health measures and addressing like BMI, for example. And I think I mentioned this a little bit earlier, but really the way we also provided feedback is with the use of the standardized tools. So because we didn't really use standardized tools before, we didn't have a reference point to be able to provide feedback to staff. But it's able to now we use all of them. So VHQ2s and 9s and daily 20s and SBIRT and CSSRs, like all of the different standardized tools that our staff use help guide them in treatment decision-making as well now in a way that we didn't have before.
Okay. And let me just follow up on one thing. You mentioned a QA team. Did you have that from the beginning? Is that something that evolved over time?
We did have a quality assurance team prior to CCBHC. It has grown since CCBHC. So our quality assurance team is a little bit larger now. And there's a lot more involvement from our quality assurance team now currently in 2023 than there was in 2017. And some of that is through kind of the development of the reports that we've made and found the gaps in our reporting and where the areas of focus need to be. We found a quality assurance team has been helpful to help follow up and provide some of that training and ongoing coaching to staff and teams. So it sounds like it's an integral part of your organization. Okay. It is very much so. Okay, great. Thank you very much. I'm going to move on to my third question here. This is back for New Jersey. Have you been successful in getting feedback on your state collected measure results to the CCBHCs in your state? And how do you typically provide that feedback?
I'll jump in again. We have a couple ways that we provide feedback. We do provide a dashboard to each of the providers. They get their own dashboard, and then they get a dashboard of a de-identified dashboard where their name is there, but all the other providers' names are taken off, but they can compare themselves to the other providers. And this has really been, they love it. And it's a little bit of competition going on, which it has helped to motivate. We have one-on-one meetings with providers to review their data and their results. We have group meetings. We haven't done that as frequently, but we have had everybody together, again, de-identified information up on the screen and discussing it. And we provide them with their performance benchmarked by some of the HEDIS measures so that they can see how they do they do compared with others across the country. And I don't know if I'm jumping ahead. I think I might be around the time lead. So the lapse in the state collected measures, I know that's an issue that you want to address, Margaret.
Yeah.
And that is a problem a little bit for us. One of the things that we have done is that we have in the internal team, we have Medicaid who has the data warehouse and the claims data. And while we don't get the formal reports, we sometimes, our Medicaid rep will sometimes say to us, I took a look at the data. I can't give you anything formal, but it looks like they're doing good with this, or it looks like that needs a little bit, that's not doing so well. So why we don't put that in a dashboard, there's nothing, we can't really, it's not a formal, a formal assessment. We are able to talk a little bit about where it looks like the data is heading.
Okay.
And that's something that we do maybe not as frequently or against all the measures that we'd like to, but in general, it's one way for us to, I don't know, kind of deal with the time delay.
No,
I'll throw it to Dr. Others and Charlotte if they want to add anything about how we share.
Right. So just piggybacking on what Vicki was saying, we also provide feedback more than once a year because the clinic measures are available much sooner than the state measures. We don't wait until we receive all the measures to start providing that feedback to the CCBHCs. So we will have a couple of sets of individual meetings each year. And as Vicki said, we also have group meetings where we look at overall performance, and we not only share that with the CCBHCs, but with leadership as well.
Okay, great. I'm glad that you shared that. I'm going to also ask Emma, not to put you on the spot, Emma, but is Oregon doing anything different that you're aware of to get feedback to the CCBHCs as you go along?
It's changed over the years how the feedback and if feedback was provided. Most recently, we did receive some like our seat report kind of after they did an evaluation of all of the Oregon CCBHCs in 2022. We did, I want to say probably in 2019, get a de-identified kind of report of the cross-state CCBHC data reports like Vicki was speaking about, and that was really cool. It was really helpful. It's kind of fun to see too as agencies.
Okay, good. Anything else to add on the subject of getting feedback on the state collected measures to the CCBHCs before I go on to question 4?
It's helpful and useful.
Okay. All right. For all of you, for all 4 of you, what would you have wanted to know about using quality measures for CQI before you started that you didn't know? And what kind of advice would you give to people who are gearing up for the demonstration or for newly reporting CCBHCs in terms of using quality measures for CQI?
I can jump on that one and just say, I made this note to myself because we've always struggled with BMI. And so I think at the very beginning, what we would have wanted to know was that the BMI measure it sucks and it's gonna suck and it's just gonna continue to not be super helpful. And so I know we are looking forward to that measure going away, but until that point, that would have been helpful just so we knew at the beginning and we could just move past it because it really did hang us up for quite a bit. And then more education on those wellness metrics for our staff teams and how they impact clients. We would have been more thoughtful and might planful around developing a better curriculum, especially for new employee orientation, because, you know, in our field, we have lots of turnover and new employees come on, new graduates out of grad school, and we need to re-educate and re-provide information. And we didn't develop that at the beginning. And that, you know, something we just didn't think that CCBHC was going to last as long as it has. And it's been wonderful. And we also in 2017 with our first CCBHC grant, we did not, you can't see the future. And we didn't realize that on April 1st, when we started our measures for CCBHC, that we would also be doubling the size of our agency in a matter of like 10 weeks. And so we were bringing on a whole other county of providers and clients at the same time. And so that those trainings and all of that had to kind of happen right over again.
Okay.
Yeah.
Thank you. Thank you. Anything from Vicki or Charlotte or Dr. Eilers?
I think there's a couple things that we, I can start and Dr. Eilers and Charlotte might have some additions, but I think very technical, kind of more technical things are one that I think that the providers struggled getting their EHRs to develop reports that were actually sort of in compliance or representative of the measure itself. So the first year, a lot of providers, when we got the data, there were anomalies and questions that we couldn't understand. And on quite a few occasions, when we sat down with the provider, the way that the EHR vendor had designed the report didn't really match the metric. So a little more guidance, and we just weren't as you know, familiar with that. A little more guidance around that probably could have saved us and the provider time and on their side money. And I think the other more technical thing about collecting this was the encounter data. So we are a PPS2 state. So we pay a monthly rate, and there's a set of the core requirements. Those codes will trigger the monthly PPS2, but to get the real data, we need all the other claims, the shadow billing, that's what we call it in New Jersey. And that needed, that needed a lot of work. There were real legitimate concerns about it. Am I, you know, from the provider side, they were used to being very conservative, and they're sort of like, well, I'm getting paid, why would I put another? And there were just a lot of misunderstandings. So then in the beginning, we didn't have that shadow billing. We didn't have all the encounters. And then that really affected the first, you know, the first year's outcomes on the state measures, because the encounter data didn't really reflect, and it looked like the cost of the service was extremely high. Look, you know, they got the whole PPS2 for the month, but they only did one thing. Well, one of the first site visits we did is we pulled up the billing against the EHR, and the very first chart we looked at, and this, you know, this is a few years ago when we started, had one billing encounter and 8 services provided.
Okay.
And so I think maybe if we had, from my perspective, if we had it to do over again, some of those details, right, make a huge impact going forward. And so it's kind of more in the weeds, but I think they're important issues.
Okay.
Dr. Iris, did you want to add anything about
Yeah,
that?
I wanted to just mention about the importance of, the clinics being part of this statewide health information exchange. And this was something that we struggled with for the early years. Various reasons, our programs, it could be an antiquated EHR, even though they're required to have an EHR, it wouldn't quite work, or just getting established, having the HIE established to get those ADT alerts for their clients, so critical, especially for the follow-up after ED or hospitalization requirement for their case management. And so that was an ongoing struggle, even though that was a critical part of it. So I just wanted to mention that. So Charlotte, do you have anything you wanted to add?
Thank you, Dr. Eilers. Thank you for mentioning the ADT. Could you elaborate just a little bit for some of the clinics and possibly states on? Did you have that set up at the beginning? Is that something that came on board later?
It came on board. Yeah.
Okay.
We had meetings. We have a state IT agency, and we had ongoing meetings with them during the project to get our clinics registered and capable of connecting with the state HIEs, with their HIEs and the statewide HIEs. This provides the clinics with information when their clients present in an emergency room or hospital, admission, discharge, and transfer alerts, ADT alerts. So what we had to do a workaround where they were giving lists of, they had a contact list, or they gave cards, to their clients. So when they appeared in the emergency room, they could show that they were going to a clinic, these kinds of things. It took a while for this to come on with all of the programs. And as you know, it's important for clinically to respond to the needs of these patients, as well as, to address at least this particular measure about follow-up.
Right. Right.
And
Thank you.
I don't want to go. I would just add that our Office of Medicaid contracted with the New Jersey Institute of Technology, and they worked with each of the providers to help them with the HIE connections and upgrading or working on their EHRs. And I think that brought us further and faster than we might have otherwise gone. It was, I thought, a real boon to the providers.
Okay. So that was something that your state organized, your state Medicaid agency organized and worked with an outside academic entity and the clinics.
Right.
Okay. All right. Good. All right. That's very useful to know. Thank you so much. I am going to turn. Yeah, go ahead.
Could I add on to that? I
Sure.
skipped over the second prompt you have there about the advice, and Vicki, something you were speaking about with your reporting really made me think about that was probably one of our main pieces of advice that we would give to a newer clinic or someone in a planning phase, is that the very first thing that we believe as a clinic that's been doing CCBHC for a while that you need in place is that reporting structure, because it is so important, and it's imperative that you have a good report writer who can be really flexible and get changes in quickly when they need to happen. We've been really fortunate with our electronic health record team of just being willing to sometimes fly by the seat of the pants, depending on what data is reporting out as and where we're needing to make adjustments, or maybe it's not coming out as we thought it would. And so really being able to review that data quickly and make adjustments We did move to a new electronic health record in 2021, and unfortunately that system is not as sophisticated as our previous system that was older. So really planning to keep whatever electronic health record you have until you're really settled into data reporting for CCBHC, because it's not something you want to go through. And we really, in hindsight, the back end of the HR, the billing side of things, the reporting side is almost more important than the front end, and what the experience is like for our clinical providers who are using it on the front end and just entering their notes. We went for the more helpful on the front end side for our providers this time around, and it's been much more challenging with reporting.
That sounds like very good practical advice. Thank you. Thank you.
Yes. Some lived experience there.
Now, again, for all four of you, Dr. Eilers alluded to the quality bonus measures earlier. Do you have any advice for new demonstration states or clinics regarding how to optimize use of the quality bonus measures to improve the quality of your services and to improve your revenue?
Well, just say, as Vicki said, we have the PPS2, the bundled rate. So that's why the measures particularly are important. And it comes with the quality bonus payments. And I'm not sure about what the PPS1 states have in regard to that. But I think, I'm sorry, what was the question?
How to optimize use of the quality bonus measures to help quality and revenue. Yes. Probably quality from your perspective.
I'm sorry, there's a question right there on the screen.
Yeah.
I think the most important thing, in designing the measures, to think about what kind of the most important goals of your program, issues that you have in the state, because you have some options in that regard. Mm-hmm. I think in our state, the quality bonus payments, were not significant in terms of, the overall payments. So they may not be a huge incentive, but I think it was important, as Vicki kind of alluded to, there seemed to be a competition among the providers, to show each other how well they could do. And I think that was, that was a further incentive. I don't know, Vicki and Charlotte, why don't you go ahead?
Yeah, I think my advice, to piggyback on what you said, Dr. Eilers, my advice about the quality bonus payments would be to make them significant enough to impact provider behavior. And there's so much to do when you become a CCBHC, and so much to pay attention to. And the providers are very focused on the changes they have to make in their service delivery. So I think that they really have to notice, right? And in New Jersey, the outlier payments, we provide outlier payments when an individual, I don't know if every state does that. No. So we provide outlier payments when the services to an individual exceed a certain expectation. And between the two, the outlier and the quality bonus payments, then it starts to be a significant amount of money. And I'll tell you, at first providers weren't very focused. And then the first year when we set out, well, here's going to be your bonus payment. And that's a combination of the outliers and bonus. If it was just the quality bonus, I don't know if it would make them sit up and pay attention, but it was enough that they began to ask questions like, oh, wow, and one provider wasn't reporting on one of the measures and realized that they were losing out, and they made sure they reported on the measure last time, because why lose out, right? Like they had some trouble with it. It wasn't that they refused to report. Yeah. They just had some trouble that they had to overcome, some barriers. So I think a big piece of advice I would give would be make it adequate to change to change behaviors. And as Dr. Eilers mentioned, that the provider competition is also really helpful. They talk to each other. They like to see. And I would add, and I don't know, something that probably should have added earlier is, and it's true for the quality bonus payments. Charlotte on the call today spends a great deal of time with each provider, right? Answering questions, going back and saying, you sent this data to us, but this is so much different from last year. Did something change? What did something go wrong? Do you have, like, just combing the data, finding anomalies, finding changes, seeing gaps, and spending a lot of time to help understand what the data is that's being sent to us, which in turn helps providers understand their reporting, as Emma said, and where their gaps may be. And maybe it's something that's got nothing to do with performance, the reason why you're not qualifying for a bonus payment. Maybe it's something to do with the way the data is collected, right? Or similar. And I think that the time and effort that the research unit puts in to bring these things to our attention is critical in the quality bonus payments, as well as all the outcomes.
Thank you. Thank you, everybody. And this really, I think this last point kind of echoes what Emma said about her the quality assurance team. There are systems in place, whether it's at the state level or the clinic level, that can support this and that can enhance the quality of the data. It can enhance the quality of the services. So this has been really illuminating. I thank you all really very, very much. This has been a very helpful discussion, I think. I do want to move on because I think that I see a lot of questions in the question and answer box. So I'm going to short circuit, I think, raising hands, although Selby, can you tell if there are people who have hands raised in the audience who are current demonstration states or clinics that have anything to add in particular to this discussion?
They don't yet. I was waiting on you to give me the heads up to do so.
Okay. I see. I think Katie Rosenthal raised a couple of people have raised their hands. So why don't we go ahead and take this, because I think this is really the meat of what this is about. So let's hear from the existing states and clinics that are in the audience. Selby.
They're free to begin. They can just unmute themselves.
Okay. Katie, I saw you had raised your hand. I can't really tell who else has got their hand up.
I can go ahead and go. I'll try to keep this brief. I think something really important to keep in mind when you're building out processes or workflows or thinking through data for CCBHCs is being really mindful that the utility and the meaningfulness and value of the metrics and the individual data pieces collected that make up that metric kind of differ depending on what your role is and the position that you hold. And what I mean by that is, as somebody who was a clinician, the metric in and of itself as it stands is helpful, but in the day-to-day when I'm sitting with a client, it's not the most useful information as it stands. And so I was told about metrics was that it was a way to assess the effectiveness of the program, and that shaped how I approached that data gathering piece with my client. And it wasn't until later when I dug deeper into the data that I realized what a missed opportunity it was for me as a clinician to make some really important clinical decisions and have really important conversations and interactions with my clients, because the way the metrics had been described to me was just as a process for evaluating, as opposed to really thinking through how to make those data pieces and metrics meaningful in the moment for a clinician with their client and the implications for the clinical decisions that you can make or should be making based off of that. So I really encourage, like, all of the metrics as they are super valuable and important, but also thinking through, like, what is the useful information and takeaway for different positions within the organization and how they can leverage that data the most effective with what they're doing.
Great. Thank you. Thank you, Katie. And I think Joe, I believe, Joe Turner, I believe you have your hand up, or you had your hand up.
Yes, Joseph Turner, state of Nevada. And I just wanted to echo a few points that I heard others make. One is the first one being that don't underestimate the amount of work that is required in order to not only gather these quality measures, but then also to be able to process them and eliminate duplicates. So really be thinking about that as you start up your CCBHC programs in your respective states, and the creation of those dashboards and everything like that should be done on the onset. Don't try to do it as you're also trying to stand up all of the CCBHCs. It's just a monumental task that I can't emphasize how much work has to go into it. And then just agree with many of the others, especially I heard plan out cause readmission. I feel like that's one of the most valuable metrics that you have. And a lot of these metrics can also be used to conduct fiscal analyses to demonstrate how much money you're saving through CCBHC implementation. Thank you.
Thank you, Joseph. It's hard for me to see who's got a hand up, but Selby, are there others? Tina Cooper?
One just went up.
Yeah, Tina Cooper. I think that's who I'm seeing. Tina, you can unmute yourself, I think. No. Okay, I cannot tell who has their hand raised. So
We have Amy Glines, who's also
Okay.
raised.
Okay, Amy,
hand.
Amy, do you want to unmute yourself?
Sure. Can you hear me?
Yeah. Yeah.
Okay. My question really is to the mental health center about the quality-based measurements. When you were showing your clinicians, are you actually giving them bonuses, and are you dividing it up like how much they contributed to that? Like, you did 10% of it, so you get 20% of this bonus. I mean, I don't have a sense for how much that is, but are you passing that on? Or is it just, and we're able to just pay you more?
I can speak for options. We have increased salaries in the last number of years to address some of that. We are getting ready to start some incentivizing like productivity levels or client facing times providers are spending with clients, because we really use CCBHC to really talk about client care. And as much as the data and the metrics are very important and integral to the services the clients receive, the way we talk about it with staff, that was one piece of advice we might give as well, is being mindful of the language that we're using, because we're not just talking about metrics with staff as numbers and that they need to hit this number and get to this number no matter what, or that's their expectation or whatever it might sound like. We really use it to drive client care and what is in the best interest of our clients, and using those standardized tools to help drive the services that they're receiving. So we have done mostly on salary side of things increases, but are looking at now starting to do some incentivizing around productivity kind of things.
Thank you. Thanks. That was a good question. I am going to stop the hand raising because I still have a number of slides to get through, but this has been very, very helpful, and I am hoping that we'll have time at the end for questions from the Q&A. So, because I see a lot of them, let me move on. Okay, So we have one more of the general webinars on July 20th. I am going to keep it on the 20th. This is designed for administrative, technical, and clinical preparations for quality reporting. We touched on some of this today. I think Joseph's comment from Nevada was kind of tangential to this or related to this, but we'll get into much more detail on the 20th. And then starting in September, we'll have 5, possibly 6 measure specific webinars. These haven't been scheduled yet, but I'm working on that. And hopefully in December or at least early 2024, we will have a webinar on the introduction to the reporting format, the reporting template that's being revised. So wanted to make you aware of that. These are some of the things that we will touch on in the July 20th webinar, working with your EHR vendor to build out the technical infrastructure, working across departments to implement what you need to do into the existing workflow, understanding codes for billing, the shadow billing that was mentioned earlier today, and making use of learning collaboratives are just some examples of things that you can do to help you with the logistics of all of this. And we'll get to that in the next webinar. So I think we'll take questions because we only have about 10 minutes left. So I want to get to some of the questions. Shweta, could you look in the Q&A box and just start reading them out for me?
Definitely.
Thanks.
Someone asked, can you share the SDOH tool that you want us to use? We have been asked by the state to collect SDOH data, but we're waiting on this. So to only put one tool in our EMR. So
yes, thank you for asking that, because actually that was asked last time. And I actually have a slide later on. Let me advance to it here. This is not the actual measure, but this will tell you about the screening tools. It is a measure that you can find online. It's one of the new MIPS measures. And so you need to have a standardized tool that lets you screen for food insecurity, housing instability, transportation, utility difficulties, and interpersonal safety. They do not, the measure does not require a specific standardized tool, but it does suggest these 5. And I know last time that somebody asked about the American Academy of Family Physicians screening tool, and that is one of the 5 that is included as being worthy of using. So these are 5 tools that I would recommend that you look at and decide what works for you. But any of these or other tools that are standardized that allow you to screen for those 5 things would be ones that are acceptable. And this slide is included in this deck. So when this gets posted, which as I say is going to be faster than last time, you will have this information available to you. Okay.
all right. Where are the CCBHC-IA grantees supposed to report data?
Okay. If you are an IA grantee and you are in a demonstration state and you become part of the demonstration, that is either as added clinic to an existing demonstration state or one of the yet to be selected new demonstration states, you will submit your data in 2 ways. The expansion grantees that are part of a demonstration state have to submit it just like every other CCBHC that is part of a demonstration state. And that will be on the reporting template that we will provide you around the end of the year. And we'll have a webinar about that. And that gets submitted to SAMHSA. Now, as a grantee, you have pre-existing reporting obligations, and those you can use that same template and you will report it as part of your annual reporting in ERA Commons. And we're not asking that you calculate this at 2 different points. We're asking that you calculate it for the demonstration and provide in the ERA Commons when you do your reporting data you have available at that point, so as not to increase your burden. So I hope that answers it. I will get a lot more into this later, and we will also have more information available in the form of guidance on it. I know it's confusing. There are just so many pieces to the CCBHC puzzle. Next question.
Yep. Someone asked if we could share the link to the evaluation report to Congress. I did share the link in the chat. So
Thank you.
all right. So I think next question is for the panelists. What tools are you using for the QI analytics? So tools that are being used for quality improvement analytics.
Would whoever asked that question like to raise their hand, unmute themselves, and clarify a little bit maybe for our panelists?
I think it's Lisa Withrow from Southwestern. Feel free to unmute yourself.
You could speak to it a little bit. I think if I'm understanding the question correctly, like what are the tools that we might use to help? What was the with
I
quality
believe, right, for quality improvement.
A lot of what they're not really use a lot of standardized tools. I'd say there are a lot more internally developed reports and kind of dissemination of information to teams and review and staffing and providing special trainings on areas of need. So if we're noticing that, like VMI, for an example, is a challenging measure for us, and if we're seeing that the metrics is a little bit low on reporting or what we're actually capturing, creating more structured trainings to address that measure specifically to provide our clinicians with more information or tools or language or all of that to use with clients and why it's impactful to clients. And then I would say we also a lot of reporting on the measures and the data specifically to see how we're doing with capturing those or meeting them or not, and making adjustments and reviewing what kind of processes. I'm not sure if that answers it, but
Thank you.
Thanks, Emma.
I think we have time for maybe one more question, and then these will go into the FAQs. So,
Okay.
but
All right.
I'll take one more.
Okay, so this is also for the panelists. I'm curious to know what EHR the respondents use. I believe respondents meaning panelists, and what their experience has been with implementing CCBHC quality measure requirements. So
again, options for Southern Oregon, we currently are using Credible for our EHR, and we previously with our initial demonstration grant, we were in a EHR called Profiler. Very different experiences with both EHRs. I would say Profiler, the one we were in initially with our grant, was much easier on that back end. So creating reports, programming things, making sure that we were able to get the data that we needed out of the EHR for reporting purposes was much easier in Profiler. In Credible, it's been much more challenging because it's not as flexible of a system, and it's been harder to report out on. So yeah.
Thank you, Emma. All right. We have 2 minutes. Maybe let me see what else we've got here. I'm going to touch on a few of the questions from the last webinar. The specs will be available at the end of August or very early September for the measures. There was a question before on the CCBHC-IAs or PDIs. Do they have to, if they're not in a demonstration state or not a demonstration CCBHC, do they have to report the state collected measures? No, they only report the 5 required clinic collected measures. Screening tools, we talked about that. And there was a question last time on whether the grantees in a demonstration state are all eligible for the PPS. And no, you have to be in a demonstration state and be selected by that state to participate in the demonstration and be certified by the state as a demonstration clinic. So I just wanted to that there. I think we have one more poll. Selby, were you able to get this poll in?
Yes.
Oh, good. Okay. Excellent. We're getting there. Well, as they're coming in, and I think you can see them on the screen, a lot of useful new information, approximately 28%, some useful new information, 60%, very little new information, 9%, not sure, 4%. And that's with about a quarter or 3/4 of the people reporting. So I want to be conscious of time. So I really want to thank our panelists, and I want to thank Shweta. I think that this has been very, very useful. I really wish we'd had at least another hour because I know that there are a lot of other questions that have gone unanswered that will be answered in an FAQ document, I promise you. And I will also try to bring in whatever I can to the next webinar in response to those questions. So I apologize that we couldn't get to all 41 of them, I think is what is up there. So I'll let you all go. Thank you for attending the webinar. Thank you for your participation and your interest. And thank you to our panelists again. I really appreciate it.